So at this time, I am pleased to introduce our next speaker, Krista Sakowski, who serves as the clinical lead for the California Maternal Quality Care Collaborative, or as we abbreviate it, CMQCC. She also proudly represents California as a nurse on the national stage, as the state's nurse representative for the Alliance for Innovation on Maternal Health, or AIM. So I ask you to please join me in extending a warm welcome to Krista as she presents an introduction to the CMQCC Obstetric Hemorrhage Toolkit. Welcome, Krista.
Thank you. Trust me, I still struggle with CMQCC, and I've been doing it for 7 years. So I am thrilled to be back in the world again. This is my second speaking engagement since everything closed for 3 years and we weren't allowed to go anywhere. I'm so thrilled to represent my co-leads on this project, Jennifer McNulty and David LeGroux, who worked tirelessly to build this toolkit and revamp it in its last revision that came out last year. I'm going to try to present almost 300 pages in an hour. I'll do my best, but I do want to give some time for questions. So I work for Stanford. CMQCC started about 17 years ago with some seed funding from the California Department of Public Health. We've really just contracted in order to do some mortality reviews. And out of all of the information that they learned in the mortality reviews, they said, wow, QI would be a great thing to do with all of this information. So that's how CMQCC started. There was 3 people that were part of CMQCC, and now we're a team of about 16, give or take, depending on what positions are filled and not filled. In addition to the bio, I work with all of the hospitals in California. So we cover 217 out of 218 delivering hospitals in California. And my job is to day-to-day do some coaching. So we do webinars and we do presentations and we do toolkits, but I directly interact with our hospitals formally and informally throughout the year. I have no conflicts to disclose. So throughout this whole presentation, I'm going to use birthing person, maternal, woman, all kinds of different terminology, and this is just kind of the slide that covers that for CMQCC. It'll be in the PDF if you want to look at it later. So like I said, the learning objectives is to teach you everything I know about the toolkit in an hour. So obstetric hemorrhage is a big deal for all of us, right? We can see by looking at this graph that severe maternal morbidity associated with transfusions has been and is on the rise and is like the leading contributor to severe maternal morbidity. This is just looking at the US, where you're talking about postpartum hemorrhage with blood transfusions and then postpartum hemorrhage that had other procedures to control hemorrhage. And again, just really showing that it's on the rise. So when we look at hemorrhage, we look at just not cases of uterine atony, but different ways that that plays into other causes of severe maternal morbidity, amniotic fluid embolism, preeclampsia, sepsis, all these other things, and whatever the cause is that you have this combined hemorrhage associated with it. So we look at all the different causes when we're talking about hemorrhage, and we try to build the toolkit to address some of these comorbidities. So when we look at the mortality reviews and tirelessly case by case by case, we kind of bucket all of those things that went wrong or things that could have gone better into different causes so that we know how to address them. And again, that we put emphasis on those when we speak, when we build the toolkit. So a lot of things associated with hemorrhage are delayed responses or ineffective care. So it's long been said about hemorrhage that people get tunnel vision, right? You see all the blood and you get tunnel vision and you just start giving meds and it's hard to get to the next step. And the data actually reinforces that. So we know that race and ethnicity are not biologic constructs, and they don't make the patient physiologically at higher risk for hemorrhage. But that being said, we do have a higher rate of hemorrhage among Black and Native American women. So while those rates are higher, we wonder what the attribution is. And what we look back in the mortality reviews and see that there are higher rates of prenatal anemia that had not been addressed, and they also have higher C-section rates. So C-sections are associated with hemorrhage actually at a very alarming rate. So when we talk about reducing hemorrhage, we can't just talk about reducing hemorrhage for just everyone. We have to see what we're doing for all races. And at CMQCC, we're able to break down all of our data into race and ethnicity. So you can see what your hemorrhage rates are in each individual hospital and see that breakdown by race and ethnicity. Black women, again, remain at increased risk for SMM for the reasons that I talked about. And we have really focused on prenatal anemia as being a target. We have a big project coming up through Stanford Obstetrics to really focus on infusion centers so that we can do some more outpatient anemia treatment with IV iron. So I'm sure everyone's familiar with these now, right? The Joint Commission Standards for Maternal Safety. Right? There was a bundle on hemorrhage, and there was a bundle on hypertension. This one on hemorrhage pretty much mimics what we did for our original collaborative back in 2015, I guess, in California. So wherever it is that you are in your hemorrhage journey, whether you're just beginning, whether you're kind of in the middle, or whether you've got a lot of these things hardwired, I really challenge you to go through all of these steps and see if the things that you initially implemented are in fact still working the way that you wanted them to, like really evaluating that. So when we walk through the steps, very simple and totally makes sense with our structure measures, like what we lay down as the foundation for treatment and care of patients with hemorrhage in our facilities. We want to complete our assessments, our risk assessments, and we'll get a little bit deeper into that in a little bit. We want evidence-based procedures so that everyone on the team knows how we're systematically moving through hemorrhages and what resources are available in our facilities. We want standardized supply kits, and so is that just on obstetrics, or do we need to mimic that in the ED? Do I need to mimic that in the ICU? Are there other areas of the hospital that could benefit? Similar to when we're talking about crash carts, we want everything to be exactly the same, so whoever's responding is looking at those supplies and they're readily available and able to see and find what it is that they need. Role-specific education, so really doing all those drills and sims, making sure that everybody that's on your response teams knows what their role is when they walk in the room, and that can look different in every facility. As long as you've hardwired it at yours, what it looks like at your facility, that's the important part. You want to make sure that you review all of your severe hemorrhage cases, and this kind of gets a little bit muddy for people. So some people say, okay, well, I'm going to review all cases where we transfuse 4 units, so a massive transfusion, right? And some hospitals will say, we're going to review every single case. And so what's the right answer? And we'll get into that a little bit later. And then we want, what we really missed when we did our original collaborative on hemorrhage was actually providing education to patients. No education was going to patients. We weren't doing a great job of educating patients in the outpatient setting, and we weren't doing a great job of discharging patients with what they needed to think of for follow-up. So there's 4 components of quality improvement, and these are kind of the pillars, and now there's a 5th R where we talk about respectful care. But previously, it was the 4 R's of quality improvement, which is readiness, like what do we do in order to prepare? How is my unit preparing? That's your drills and your order sets and your policies and procedures. Recognition is the 2nd R, so are we actually noticing when we have a patient that's in trouble? Are we doing quantitative blood loss, and what part does that play in diagnosing hemorrhage? Are we actively managing our 3rd stage of hemorrhage? Our response, are we actually doing what we said we were going to do? So I'm sure that you're familiar with the CMQCC stage-based treatment. That is what's recommended by the Joint Commission. But are you actually following that, and you're following that consistently with every case? Providing support, again, for your patients and families. And then the 4th R is system learning and reporting. So are we doing case debriefs? Are we doing case reviews? And we'll get into it a little bit later about how important that is and what role that really plays in real life. So readiness, the ongoing risk factor assessment. So where we were kind of missing the boat here is that we were, admitting patients in our EHRs, doing our assessment when they walked in the door, but we weren't doing anything prenatally, or we were doing the obvious things prenatally, okay? Like this patient is at risk because they have a coagulopathy or something like that, but not really breaking down our individual patient's risk prenatally. So that's become a major factor in this last revision of the toolkit, where we really examine where the patient is prenatally. And this could be refusal of blood products for whatever reason, again, coagulopathies, questions about blood transfusion, what their actual risks are, previous C-sections. So really having that discussion with our patients prenatally. All patients should go through that not only prenatally, but on admission. And then we say anytime the patient's condition changes, right? So if something, now they weren't on Pitocin and now they are on Pitocin, we want to reevaluate what that patient's hemorrhage risk is. When the patient delivers, we want to reevaluate what that patient's hemorrhage risk is. So this is continuously happening throughout the hospital stay. Transfer to postpartum has become a big highlight, something that we were never looking at before. It was like admission, delivery, we forgot about it, we don't address hemorrhage risk. And for some of us, our postpartum units are not equipped with the same supplies. They don't have ready access to physicians the same way that labor and delivery does. So it's really something that is almost more concerning that we were not doing previously. So that's been addressed in this update of the toolkit. Despite all of our risk assessment and our best laid plans to predict who's going to bleed and who isn't, 40% of our postpartum hemorrhages have no risk factors. So what does that really tell us is that we need to always be ready. And that is the point of all of this preparation with our drills and sims, our supplies, our procedures, and our stage-based care. So this is the updated admission. I'm really getting used to this confidence monitor. It's really wonderful, but I keep looking back. Our admission risk factors. These have changed just a little bit from the previous version of the toolkit. And why do these things make the list, and why did things change? So we look at all of the evidence that we have out there, any new papers, anything the task force pores over all of these things and collects them into a nice little chart for you, so you don't have to do that. And occasionally adjustments need to be made, or we find something different. So in the gray here is all of the things that were updated from the previous version. And I really pull that out because if you had at your facility either had a paper that you used for a risk assessment or you utilized your EHR, it's a change. It's different. So you might need to go back and look at what your facility is utilizing and make sure that it's updated. So that's one of the key things that we pull out here. The purpose really of risk assessing the patient is not to put them in a box, right? Like I get questions like this all the time. Like, okay, if this, then that. Is my patient medium risk or high risk? And the point of it is that what is the care associated? What is the readiness and what is the preparation? So we do, some recommendations as to what you might do for a low risk patient or a medium risk patient or a high risk patient, but they're not set in stone. This is just an example. Your facility might have copious access to blood bank, and so your response might be a little bit different. You might be able to run labs quicker than another facility, or you might be a rural facility and have a long duration between these things, so you would want to do more preparation for a medium risk patient than a high risk center. So this is also what was added with the Joint Commission saying, okay, we need to ongoing assess our patients. They're not out of danger after they deliver. We still have postpartum risk. So these were the things that were added of what happens during the delivery that can put the patient at a higher risk for hemorrhage. These are very well established, and it's a shame that we weren't doing it before because now it just seems like an obvious one, right? Makes sense. These are the things that as nurses and physicians and midwives that we catalog, right? We catalog in our heads and we're like, I know this patient's at risk for whatever, but this kind of puts it on paper, gives you like a very succinct way of looking at patients and thinking about risk, and it puts all of our care team on the same page, right? So whether we're brand new nurses or we've been around for 30 years, we're all on the same page of how we assess patients for risk and what we do in response to that. So when we think about risk, when we want to build what our response is in our facilities, what are we thinking of? Like, what can we do to prepare differently based on risk? Well, the hemorrhage cart, where's the location? So I visit hospitals in California, or I used to, now we're getting back to it, visit hospitals in California, and they want to show me the unit. And I love to see units, and it's amazing how different you've seen one L&D unit, you've seen one L&D unit. Like, that's basically how it is, right? And they want to show me, they're very proud of their hemorrhage cart because it's got all of their supplies, and they've got a list, and they've got all the checklists, and it's in a closet behind the OR. I know it's not being used. It can't possibly be being used as often as it should be based on risk, right? Because it's impossible to get to. So just really the location of your hemorrhage cart, and if you have a patient that's high risk, you might move it right outside of your room. And that's a couple of things. One, you've got ready access to your hemorrhage cart, and two, it's a signal, right, to everybody on that unit. If you haven't done huddles, or they didn't participate in huddles, or you don't have it earmarked on your grease board, it kind of is a signal that this patient is at risk. So if a call light goes off, or people hear noise, and they know that that's a room that they want to go into, and they know the reason why, right? Consideration of hemorrhage risk can be a factor in your staffing ratios, right? We will think of patients that are at very high risk for hemorrhage. We might want to consider how we're staffing, what our ratio is for nurse to patient, and think about that when we're scheduling for the day, or we're thinking about canceling or anything crazy like that, which is a terrible thing on L&D, right? Ensure that all our QBL equipment is available. So how do you measure QBL at your facility? Do you use infant scale? Do you have a separate scale? Whatever it is, colorimetrics, do you have that equipment available so that you're not kind of looking for it when the delivery happens? And you want to prepare for the possibility of emergency. So this is communication to the affected team. You might be in a high-risk facility where I do a stat page and everybody shows up, so we don't need to apprise people of what our risks on the floor are today, because we have immediate response. If you're in a smaller facility, or a facility that doesn't have an OB/RT set up that way, you might want to call everybody who would be responding if you had a severe case, and just give them that heads up, kind of like what we do with our nurseries or our NICUs, like, I don't know about this baby, the tracing looks a certain way. Just kind of give them that heads up. So that might be appropriate in your facility, so something you want to think about associated with your risk assessment. Your blood bank orders. What do you need to do for blood bank orders? Do you need to pull paperwork? Is it something that's easy to put in your computer? Whatever it is, you want to get some preparation associated with that. Do you want to place the patient in a room close to the OR? So if this is a patient with a previa, do I want to consider what her placement is on the unit to make it easier to get back to the OR should that be necessary, right? In an emergency. And you want to make sure that the area is cleared of obstructions. So are you in a hallway that's got IV poles in it and wheelchairs or whatever, and are you able to access the OR readily? Consider the potential use of a rapid infuser. I worked at a facility for years that we had a rapid infuser and we trained on it, but we didn't have enough blood to use it. What was the point? Right? So we had it and we could call for it, and every year we had to train on it, but we didn't have enough blood to use a rapid infuser, so it was a useless tool, right? So you want to consider that, like what is available here and how do I use it, and is it of any utility whatsoever? And that's with any of your technology, colorimetrics and all that stuff. Increased patient surveillance. Do you want to round on this patient more often? Do you want your provider to come see this patient more often? What's your schedule of communication between nursing and provider? What should that really look like when we're talking about a medium or high-risk patient? Vital sign and fundal checks. Does this happen more often with this patient because they're at higher risk, or do we just do the routine of vital signs and fundal checks that we always do in postpartum? And really assessing bleeding, right? I mean, we've all seen it. How's your bleeding? It's fine, right? Or it seems like a lot, and you go, yeah, it always seems like that, right? But and not everyone actually looks, right? And we know that not everyone actually looks. So really doing those assessments and really thinking about how you're evaluating these patients and what you're really looking for. And again, your medium risk patient might have a different response than someone else's facility's medium risk patient, and same for high risk. I do a critical access group in California. That's 8 hospitals. They do less than 40 deliveries a year, each one of them. And they have to have all this hardwired. And I tell them all the time, you could teach my big hospitals a thing or two, because everything that they do has to be hardwired because they don't have resources and they don't have staff. So really thinking about what is appropriate for your response. I think that sometimes people open up the toolkit and they're like, CMQCC says, right? And they want to do everything from top to bottom, but not all those things are appropriate for your facility. So we do give examples, and I'm always available, c.sakowski@stanford.edu, to kind of walk you through and talk you through, what are the resources on your unit and what might be appropriate. And then you can take that back to your care teams and kick it around and kind of come to a place where everyone's happy. So our prenatal considerations, right? We talked about risk assessment prenatally. Their iron deficiency anemia has been, like I said, in California has been identified as a big problem. So we have really been working on, like I said, those outpatient infusion centers. Really is no real good excuse for a patient to be admitted to L&D with, an H&H of 8, right? Like that doesn't make any sense. So we can do better. It's frustrating, right, because we'll do 1 or 2 unit transfusions in the hospital because somebody was admitted with a low hemoglobin, right? But we know that that's an opportunity to improve. Sometimes we get siloed, right? Within our 4 walls, we can't control that, so it doesn't matter. But it really is a communication thing between, the facility has that information, we have that data. We can share that back with our providers. We can work on infusion centers. So this is all possible, and it's become a new focus for us in California and hopefully nationally. Those coag disorders that I talked about, that's sort of an obvious one, right? If you have a coag disorder, you've got to address it. And the declination of blood products, this one is a sticky one for me. And I get caught with this with my critical access hospitals, right? If a patient doesn't know, if you haven't walked them through all of their options, if they decline blood products and ask them why they're declining blood products, and it's not all religious, right? You don't have that opportunity to have that real conversation where you're talking about risk benefits or the products that they would be able to have or the products that they would agree to. Prenatally, this is a great time to have this very calm discussion. While the patient's bleeding out, not a great time to have that discussion, right? So it's really our responsibility and our obligation to really thoroughly do a risk benefit, and we get to see these patients for, anywhere from 10 to 13, 15 visits prenatally. So we've got a lot of opportunity to have these conversations, and it's important to really reinforce that. Depending on what your facility looks like and what supplies and products that you do have, you might want to outline that. Do all the nurses even know what's available? Probably not. A lot of times anesthesia doesn't even know what's available, especially if you're in a smaller facility and you've got, the quote unquote moonlighters. They run through different facilities. They think that they have certain products or certain volumes of blood in that facility, and they don't, but they don't know it. So these are all things that we think about. What our consent form will look like for a declination of blood products really should be very clear that I decline this, but will accept this. So now you have this roadmap. And again, not just relocating it to patients of specific religions. And then obviously your placenta accreta spectrum. So this is something that we obviously should diagnose prenatally, but it does get missed. It does get missed, and there's been all these studies on is ultrasound better than MRI, MRI better than ultrasound, and it really is kind of a wash. We're still gonna miss a few. But when it is identified prenatally, we wanna think about where that patient should deliver and how we should prepare. So the management of iron deficiency anemia, the focus is going to be on, we don't want patients to come in anemic. We want to decrease that risk of transfusions. Like again, those 1 to 2 units still carry risk, right? So if we can treat this patient with IV iron or PO iron, if we catch it early enough, then we avoid that risk of transfusion. And I mean, we're on a crazy blood shortage now again. So we want to make sure that we are utilizing our blood supply responsibly, and treating our patients for anemia would help with that. And then it improves postpartum recovery, right? I always feel like that. Like we discharge a patient with a hemoglobin of 9, and now they have to go home and take care of a newborn and recover from a vaginal delivery or a cesarean. Like that's setting them up for failure, right? And we know it, and we're just setting them up for failure. So can we treat them in the hospital before discharge, but ideally that prenatal? Obviously, oral iron is preferred. It's easier, but we really want to make sure that we talk to patients about side effects associated with iron, like the constipation, the nausea, so that they don't think that it's something specific to them, like, I don't tolerate iron. Well, nobody really does unless you do X, Y, Z, right? So we want to make sure that we have those thoughtful discussions, or we'll write the script or tell them to go pick it up, and then they'll pick it up and never take it or never pick it up. So we have to have that constant communication and education with our patients. And then the IV iron treatment, which I talked about, has been a big deal in California. So our bleeding disorders, we want to make sure that we identify them early in care. Do we refer these patients to maternal fetal medicine? The answer is almost always yes, depending, but it's almost always yes, so that you get that full big picture. If there's any other additional labs that need to be ordered, if there's something else that we need to consider with that patient. And then we should certainly let our care team know on admission, right? We want anesthesia to know that there's a coagulopathy. We want any physicians involved in care that there's a coagulopathy, and certainly nursing. I already talked about this. Okay, so the thing that's different that we have made this recommendation about is that if we have patients that we know are gonna decline blood products, because we've had that wonderful discussion prenatally, the target for their hemoglobin would be a little bit higher. So we want to try to get them at 12 instead of 10, which is kind of the earmark. So how do we do that? Oral iron, or we can supplement that nutritionally. But kind of the research shows that if patients are really iron deficient, that usually they can't catch up with diet alone. So just something to keep in mind. So placenta accreta spectrum, why is this such a big deal? It's such a big deal now, right? I've been a nurse for a very long time. I just look great. When I first started working, we never saw this. We never saw an accreta. I think I saw one in 6 years. Like, we never saw it. We have facilities now that are not even accreta centers that have 3 a month. And why is that? C-sections. Our C-section rates skyrocketed. I mean, in California, we are at like 22.8 now, but that's like years of work, like years and years and years of just active work on cesarean reduction. We have states 30, 35%, approaching 40% C-section rate. So all of these C-sections put our patients at risk for accreta spectrum disorders, and that's because the placenta has to adhere somewhere, and it doesn't do a good job of doing that on scar tissue. Right? So now we've got placentas doing weird things because we've created an environment where they can't adhere normally. So that's just something to keep in mind, that if we want to reduce our placenta accreta spectrum, we need to reduce our C-section rate. So these go hand in hand, and then when we do that, we also reduce our hemorrhage risk. So it's everything goes together, right? Every cesarean obviously is going to increase your risk for placenta accreta spectrum. We talked about ultrasound being kind of the preferred because it doesn't really pick up any less PAS than MRI, and it's certainly much cheaper and readily available. We get the best outcomes with PAS in centers that are accreta centers. And this is such a sticking point, right? Because accretas are going to wind up everywhere. You're going to get one, right? So we want to put patients in accreta centers because they're going to have the most blood utilization readiness. They're going to have in-house anesthesia, in-house physicians. Maybe they are going to have ready access to uterine artery embolization. The problem with that is that then when patients walk into regular hospitals that are not accreta centers, are we ready? Are we prepared? So we want to appropriately have patients deliver in centers if we know about it, that they belong in, but we still need to keep all of our units prepared for the possibility of PAS that's undiagnosed. We have several videos. I'll attach that about the aftermath of placenta accreta spectrum and what that looks like for patients. And we just feel like we did a good job, right? Baby was born, mom lived, everything's great. But this trauma-based care really can start prenatally when we know that patients have PAS. We know that there's a high risk of them having a poor outcome or a traumatic delivery, even if the outcome is great. So we really need to apprise them of that. I worked with a doctor one time that didn't want us to call hemorrhage codes, because she thought that it would alarm the patient. I'm like, well, we need everybody that we need in the room. The patient's bleeding, she's probably alarmed, So you know, we think that if we keep some things away from our patient because it hasn't happened yet, that they'll be calmer and safer and happier. But really what patients have told us time and time again is that they want the information. They desperately want the information. So this is a good time for counseling throughout the prenatal time, on admission, so that they feel informed about their condition and they can have real conversations with it. So if something goes sideways, they're obviously not 100% prepared, but they have had some of that background information because, again, just like we talked about earlier, that's not a great time for that conversation, right? So we want to prepare our patients as much as possible, and that's what they've been telling us loud and clear, so we need to listen. And then attempts to remove the placenta prior to the hysterectomy should be avoided, so we want to take everything out at the same time. Hemorrhage carts. So I talked a little bit about these, about location, right? We talked about location of hemorrhage carts. Your hemorrhage cart might look different than my hemorrhage cart, again, depending on where your supplies are and where they live. And why is the hemorrhage cart like so important, right? Like we have all this stuff on the unit, yeah, and you're running all over looking for it. Or you can't find the right size, or it's in a different package now. I mean, that's the worst one, right? New vendor, can't find it. So you want to make sure that you make a list for your hemorrhage cart and that you actually check it. So some hospitals lock these just like crash carts, so they have the little tags on them, so I know when it's been opened that I need to assess it for restocking. Some do exchange systems, some don't do it that way, and then they have like a tech or a nurse assigned to check that cart every shift or once a day, whatever's appropriate for your unit. But these get pilfered often, right? I need another IV setup or whatever, and you're like, oh, hemorrhage cart's right outside the door. I'll put it back, and then they don't. So that should be like kind of the standard on the unit, that these don't get touched for anything other than a hemorrhage, you know, like under penalty of law. But that you really maintain that this is like a sacred space and that this hemorrhage cart is just like a crash cart, because there's nothing worse than like opening a drawer and thinking that something is there and then it's not, right? That's the whole purpose of this cart, is to put everything in one place. Some people have these wonderful carts that have a refrigerator on them so they can keep all their meds together. Most hospitals don't have that, but I'm very jealous of the ones that do. That seems amazing. So your med pool, it might be a little bit different, right? Some hospitals have a serial med pool, right? You choose hemorrhage kit and then like 4 drawers open and you pull your serial meds. Some have little bags, believe it or not, and you know, you go to one hospital and that's the way they do it. Another hospital, the pharmacist is like, absolutely no can do. Can't happen. So you got to check with your pharmacist of how can you quickly get these meds and what's the best thing that works in your institution. So, you know, if you have that cart with does anyone have that cart with the fridge? No. You do? Oh, it's so great, isn't it? Yeah, it should be the standard, but it's not. We usually get like an old beat up cart that was probably in like maintenance for 40 years. That's usually the carts that I see. But they work, you know, it works. And then making sure that that cart is someplace that actually makes sense, right? That it's readily accessible, and normalizing pulling that cart. I mean, I would pull it for any medium risk patient. You know, like in my facility that I worked in is small. You know, we don't have a whole lot of ancillary resources. So I would pull that for a medium risk patient. We only had 10 L&Ds. It's not like the cart was hard to find, right? So think about where it belongs. And then I've seen little mini kits that some hospitals will put like an ICU, which is like a rare place that they would have an OB patient, but does happen. But they don't have room for a whole entire cart. Right, so they'll do some like a little bit modification of that. As long as everyone's trained to it and it's standardized, that's great. But think about all of the areas in your hospital that could benefit from having the cart. ED, does it make sense for ED to have a cart or a little box? When OB responds to things in ED, if that's how it works in your facility, do they know where it is? Can they find it? So all of these things seem like so super simple, but they have to be thought about. They have to be thought about and they have to be roadmapped, and that's everything that California does for QI, right? Everything is like structured. We try to structure everything and standardize everything as much as possible so that the communication is very clear between all the team members. We're lots of smart people in this room, right? We're all smart. We know what to do, but we need the resources in order to do it, and we all need to be speaking the same language and have like the same mechanism of response. So that's where sims and drills come in. How many people do annual hemorrhage drills? Biannual. Yeah, okay, great. So again, I learned this from my critical access hospitals. They're like beasts for SIMS and drills. They've got it like hardwired. They have, if they don't have a mannequin, they like do the best that they possibly can. But they're drilling hemorrhages quarterly. And if you think about it, you know, when your response is minimal, the resources for your response is minimal, that really makes a lot of sense. So think about your facility and what your resources are and what real schedule makes sense for hemorrhage. Are you doing it in a conference room like this? Does that make sense? Does it make more sense to do it in your rooms where all your supplies are, right? That seems like it makes a lot of sense. Like, what does this actually look like? Do your physicians and midwives participate in your drills, or is it just nursing? That's also a problem. Does anesthesia participate in your drills? Because they always have a lot to say, right? Our anesthesiologists have a lot to say about what we did wrong. So it would be nice, you know, and I think there's a lot of learning that happens that way. You know, I started pulling anesthesiologists into my drills, and they were really helpful in kind of connecting some dots that we didn't really understand as nurses, right? So what actually is anesthesia doing? It's really that opportunity to have those connection points. So I encourage you to include anesthesia in these. Your techs, your ICU nurse, whoever it is that's going to respond if you have a severe hemorrhage should be included in these drills as much as possible. And doing them once a year is probably not going to capture everybody, right? So it's just something to think about. I know it's difficult, but it's just something to kick around in your head, like how could you improve your drills and sims? Like what would make them better and make them more efficient for your hospital? EHR, so David LeGroux, one of the co-leads for the Toolkit, is like really into informatics. And you can see why. There's like lots of great reasons that if we can build things into our EHR, that they improve care, streamline care and make things a little bit easier for us and improve care of the patient. So what can we build into our EHRs? Well, we can have documentation templates so that we don't miss any of the information that we're trying to catalog when we're talking about writing the summary of the delivery, like hemorrhage, 1200. That's it, right? Like not everything is captured there. So like your abstractor's trying to figure out if transfusions were given and what meds were given, and you have to look 82 different places. So these documentation templates can actually pull in from other places like your MAR and your transfusion log into one little note. So that's a way that we can use documentation templates. Your BPAs, your best practice alerts, so your low blood pressures associated with hemorrhage, tachycardia, these are signals for us. Standardized order sets, utilizing our management algorithms, so that's stage-based care, or however you've tweaked it in your facility so that it looks the same for every single patient. Communication tools, and reporting and communicating status and evolving trends. So David's got like all trend lines and everything in his EHR. Most of us don't have that. Our early warning systems. So does anyone use a Muse or a Mute system in their hospital? Yeah, okay. So these have not been super hardwired for OB. We're still tweaking them. I'm working on a sepsis project right now where we're trying to even fine tune it more because those systems have not been working great for us because they've been, you know, kind of flagging a lot of patients like a false positive. So we're working on fine tuning those obstetric warning systems, but hopefully we'll get that figured out and then they'll be more useful to us. And then care pathways that have potential, they have a potential to improve quality infrastructure and obstetric care, including hemorrhage. So we have a couple physicians in California that work really hard on nurse pathways. So like once we trigger the order set, there's things that nursing can do as a part of that order set that don't require direct communication with the provider at that moment. So this is another way that we can utilize our EHRs. So this is just a bunch of examples from David of all the ways that you can use your EHR to improve your obstetric outcomes, and this will be in the PDF of the slides. We talked a little bit about this, the hemorrhage preparations for small and low resource hospitals. Sometimes we don't think that we're the smaller or low resource hospital. That's why it's nice to be in big groups like this where we can share what our experiences are and see like, oh, you have the cool hemorrhage cart with the fridge. See what different resources people have and kind of share back and forth and say, oh, we could really benefit from that. Our volume of hemorrhage is this, our volume of patients is that. We don't have in-house physicians, whatever it is. So that's good to compare with other hospitals in your state and what the resources are. Communicating and collaborating between departments. So if you're in honestly, even if you're in big hospitals, this happens, but especially if you're in small hospitals, if your response team is coming from the ICU or a member is coming from the ICU, we have to hardwire what that communication looks like. That ICU nurse can't just show up and go, what do you want me to do? Right? They should know what their response is associated with hemorrhage. What is our connection with our ED? Does ED handle all of the OB patients and they just do telephone calls? Does OB go down to the ED for every obstetric patient? What does that look like? What does the training look like in the ED? Are they receiving the same drill training that you are on OB? They should, right? They should, because they should be responding in the same way. It's long been, hardwired in surgery that you can't have a surgical procedure in one part of the hospital and have a surgical procedure in another hospital, a part of the hospital, and it be different. That care has to be the same regardless of where you receive that surgery, right? That's a standard of care. Same thing with hemorrhage. So we shouldn't expect that if the patient comes through the ED that they have less of a standard of care. They don't have all the same resources that they would if they were on OB. All staff need to have a clear picture of response times and, like I said, what products or resources are available in your facility. We think we start a massive transfusion protocol and the blood just comes from I don't know where. We need to know how long it takes. Do I have 10 units that are in this facility and then blood bank is 30 minutes away and it takes an hour to get more blood? That's important information for anesthesia to know, for the docs to know. So when we're treating hemorrhages, that we're all on the same page and we know that it's not limitless. Or maybe we want to respond a little bit earlier with this patient, whether it's DNC or a balloon or whatever. We want to respond a little bit earlier because we don't have that much blood here. We want to really minimize how much blood this patient loses. And a physician that practices at multiple sites might not be aware of that. At the site that they work at most of the time, they've got a certain availability. So it's important to keep everybody on the same page. And in a small facility or a low-resourced facility, teams should be mobilized early, right? So when we're talking about like our risk assessment for a small hospital, we're going to prepare maybe a little bit different or a little bit earlier, a little bit more comprehensive than we would at a hospital where everything is at our fingertips. So it's just something to think about, not waiting until we hit that 500 mark or that 1,000 mark, right? Really thinking about what that looks like. So recognition. So this has been like a very confusing thing that's not really changed, but we really need to delineate it. A hemorrhage is over 1,000. That's it. That's the definition of hemorrhage. It's never been different. It's never changed. It's never been 500 for a vaginal delivery and 1,000 for a C-section. What 500 means is that that's abnormal. Over 500 cc's for a vaginal delivery is abnormal bleeding. It's not a hemorrhage, but it's abnormal bleeding and we should respond to it. That's what the 500 means. It doesn't mean that this is a hemorrhage. It means that we should have a response to the abnormal bleeding, and the argument has been made and can be made that it should probably be the same for cesarean, and I agree with you, but this is the way that it is, okay? But that's what the signals are. At 500, we should be responding to this hemorrhage, we should be treating it, we should be thinking about what the next step is for a vaginal delivery because it's obviously abnormal. The other thing to keep in mind is the with continued bleeding. So we made this whole emphasis in this toolkit with continued bleeding because there was like lots of lost in translation. Okay, so the patient lost, 550, 600 maybe, and now it's stabilized. Patient stabilized, fundus is firm, bleeding is normal. Do you need to transfuse that patient with 2 units? No, right. So it's like with continued bleeding, you don't just go to the next stage because of the number flagged. If the patient is continuing to bleed, then you should go to the next stage because your hemorrhage isn't managed. So does that make a little bit of sense? Kind of how we're looking at that. So the active management of the 3rd stage of labor, so this is like what we do, right, after the baby is out. So when we looked at all the research for active management, the thing that was really key is the PIT. So Pitocin administration is like the really key thing. We do want to standardize. We do want to keep doing that. Delayed cord clamping doesn't appear to have any increased risk for hemorrhage. I don't remember where that came from. And there should be a unit standardization of your oxytocin administration. So I have a whole chart that I'll put in the PDF, but we looked at all of the research on Pitocin regimens, giving this much and then giving that much, what we do prenatally, what we do postpartum, all the stuff. And basically it showed that there was no perfect regimen. They all had basically the same efficacy. So whatever your hospital's doing, just do it your way, but it has to be done the same way all the time. So that's all we're touting. You can give 10, you can give 30, you can put it in 500, 1,000. Doesn't really matter. Just make sure that you give it to every patient unless they decline. So we dove a little bit deeper into describing what blood loss looks like, right? Because that's literally what we used to do. What does the blood loss look like? Looks like 500, right? So for EBL, and so we want to totally throw EBL away, right? We don't want to do that anymore. Is quantified blood loss perfect? No, and it can't be. It can't be perfect, right? But is it better than EBL? Yes. I mean, it's infinitely better than EBL, but you can get in arguments with people all day about this. It is not perfect. It's not going to give you an exact, obviously, but EBL was never going to give you an exact or even close, and is up to 40% wrong. So it's proven that quantitative blood loss is much better, so we want to make sure that we do that with every patient. Why do we do it with every patient and not just patients that are hemorrhaging or that we think are hemorrhage or bleeding heavily? We do it because we need to be good at it, right? We don't want to be fumbling in the severe hemorrhage trying to figure out like, oh, do I weigh this? Do I drop that? I didn't zero the scale. Whatever it is, however you do it, your colorimetric system, if you're using colorimetrics, you want to make sure that everybody really knows how to use that in an emergency and when your tension's high, right? So if we do it on every single delivery, it's raw, just like all of the other things that you do in a routine delivery. It's just raw. You practice it. You know exactly where all the supplies are. You know how to do it. It's hardwired. I always recommend that people start with vaginal deliveries because it's a little bit easier, and then move into how you're quantifying your blood loss in the OR, which can be a little bit more complicated depending on what your layout is and what your resources are. But this is very important to do this with all deliveries, not just ones like, oh, I think this patient's bleeding a lot, let's start QBL. You've missed an opportunity and you're probably not going to be great at it. It takes, when we did this research on QBL with a couple of our small hospitals, it took like 8 or 9 months for them to actually get the numbers right. So that was with doing it with every delivery. So you're not going to be good at it if you don't do it. And that's why we recommend QBL on every patient. So we talked about gravimetric, so that's weighing it. Volumetric, that's what's in your canisters, right? The color metric, that's the Triton system. Does anybody have that? Triton? Yeah, that's really cool. It's an iPad, and you take pictures of like the lap sponges, and it tells you how much. We have 3 hospitals with it in California. And then your CBL, your cumulative blood loss. So what does that look like, not just at this time of delivery, but over the course of the patient's stay, right? And that might cause you to treat the patient differently. So let's say the patient lost 800 in delivery, and you maybe gave some Methergen, and the patient stabilized. And then they go over to postpartum, and they start bleeding again. So you want to think about like how much blood loss has that patient experienced during the whole visit. That doesn't mean you're going to do a stage-based approach, 2 days later, but it's a consideration for you to know throughout the whole patient's whole stay how much blood did they lose, and cumulative blood loss is how you do that. So our clinical triggers, is everybody familiar with it? Did you read it from cover to cover, all 279 pages? I bet. The clinical triggers are just kind of how we've organized stage-based treatment of hemorrhage, right? So stage 0 is all bursts, and that's where you're going to do your active management of the 3rd stage, right? That's our Pitocin. That's what stage 0 is, totally normal birth. Stage 1 is when you have that greater than 500 vaginal or greater than 1,000 C-section with continued bleeding, or this is an addition, because when we did, we patted ourselves on the back for doing such a great job with Atney, and then we found all these concealed hemorrhage cases, and deaths associated with concealed hemorrhage. So now we were like, okay, expanding our mind now that we figured out, not entirely, but better how to treat Atney. What else are we missing? So if you've got vital signs that are abnormal or trending abnormal, you want to pay attention to that. And there's a couple of EHRs that have this shock index built in, which is not easy to calculate in your head, but is actually quite amazing at predicting if patients are in trouble or not. So you can build that into your EHR and tell David I said that. Or confusion, right? Like the patient's not acting right. she must be really tired. That must have been a long labor, right? And really kind of explaining away, which we do, that normalization of deviance, like explaining away why that patient might be acting weird without doing a full assessment. Do I need to feel a belly? Do I need to take another set of vital signs? Do I need to look at this from a different perspective? So just something to keep in mind. Stage 2 is that continued bleeding, so that's less than 1,500 mils, or the vital signs remain abnormal. And then stage 3 is like the really bad bleeds with over 1,500. You've already given 2 units, abnormal vital signs, or suspicion of DIC, so for whatever reason. This is one of the ways we've depicted this same chart 3 different ways in the toolkit, and we tried to consolidate it, and everyone got mad. Everyone had like their favorite version of this chart. So this one is the flow, and this one kind of shows you that whole perinatal part that I talked about all the way through the postpartum. So it's not as detailed as the chart version, but it's going to give you that total picture prenatal to postpartum in one page. I already talked about that. So when we evaluate our patients for hemorrhage, what are we looking at? Okay, so patients bleeding. Atony seems to be the first place we always go, right? And that makes sense because that's usually the cause. But what else do we need to look at before we get tunnel visioned? All right, I've given the meds. Patient's still bleeding. Doesn't really feel like a boggy uterus, but she's bleeding, so it must be, right? What else do we need to look at? So our vaginal examination to really look if there's any kind of tears or hematoma, anything like that. And do we do that well? Do we have good lighting in our room? Is there another light that we need to bring in? Do we need to take the patient back to the OR because that's where the really good lights are? That's where I can really see. That's where I can get the patient in stirrups. Whatever it is, really doing a good vaginal examination, an exam of the placenta, which seems to be one of those later things that we look at. Your uterine examination, do you need to get ultrasound to see if there's any retained products? Really a good abdominal examination, especially if we have a patient that's C-section. Is there any kind of retroperitoneal bleeds? Is there any kind of arterial stuff? Hematomas in the belly. So we really need to do a really good examination and really think about that for our cesareans. And then evaluation for a coagulopathy. So if we didn't pick it up prenatally or the labs weren't run, or there's some other labs that we need to run. Not so common. So if you see early warning triggers and you don't see enough bleeding, you have to consider a workup for concealed hemorrhage, right? This looks like a hemorrhage, but I don't see any blood. Hypotensive, don't see any blood, right? Tachycardic, don't see any blood. Patient's acting weird. Patient's complaining of a lot of pain, either abdominally or, the hematoma, the pain when they complain about perineal pain, and you're like, I gave, perk or whatever, and they're still complaining. You start thinking, why? You take care of patients every day that are perfectly covered with that pain management. Why is this patient really complaining of this pain? So it's just an evaluation piece. So always consider the differential diagnosis when we're talking about concealed hemorrhage. So did the patient have a prior cesarean? Are we talking about post-op in a cesarean? Abdominal pain? We already talked about this. Cervical and vaginal lasts, rectal or perineal pain, unexplained confusion, and choreo. So choreo is associated with increased risk of hemorrhage. Rapid response and emergency activation. So this has been a huge thing for me since I've been working for CMQCC for almost 7 years. And our ability to silo ourselves from the rest of the hospital is quite fascinating, isn't it? We got it, and we don't have to got it, right? The rest of the hospital has RRT, and we feel like RRT only works, rapid response teams only work for us if the patient is having some kind of other medical emergency that's not obstetric focused. Why? Oh, that's not what we do here is obstetric emergencies, so we should have our own obstetric RRT. That can be made depending on what the resources in your facility are of team members that are on your floor. That can totally be your whole obstetric rapid response team is made up from members that are on your floor. But in a lot of cases, you're going to need other expertise. Our ICU nurses are like bosses at fluid management. Let's get them in here. They should be part of our rapid response team for OB, especially when we're talking about a hemorrhage. They're a great right hand to anesthesia, who's also an expert at fluid management. So these are things that we want to think of when we're building our obstetric rapid response team. Who should be on it? When should they be called? How should they be called? Does a pager system make sense? Does overhead make sense? Does both make sense? But really hardwiring these OB rapid response teams in your facility. I promise you that the payout will be tenfold. It's a little bit of work to kind of get it organized. It's a little bit of work to train in, ICU teams into your rapid response, but then everybody knows what their role is when they walk in, and you know that you have responded to this emergency as best as you possibly could, right? You've got all the right players and you haven't waited. That's the whole point of a rapid response. The whole point of those teams was when the patient started getting a little bit weird, that you would call the rapid response team and they would have more eyes on them. And so we should think about that a little bit more for OB teams. And then we need to drill it. So if we're utilizing an OB rapid response team, we need to drill that in our drills and sims that we're going to be doing biannually or quarterly now. So cumulative blood loss shouldn't be used in isolation. So this is back to concealed hemorrhage. So we're not just looking at how much blood the patient lost. We need to look, make sure we're checking vital signs and level of consciousness. So response. Medications for hemorrhage have not changed very much. Oxytocin is for prophylaxis and treatment. Second line is our Methergin and our Hemabate. Miso, we stopped recommending miso because of the tachycardia associated with miso, fevers associated with miso, diarrhea and vomiting, which you can get with Hemabate as well. But miso started making patients look like a train wreck. They look worse than when they were hemorrhaging. So we do still give it, but you're going to give it for patients where those other meds are contraindicated. So you can't give Methergin, you can't give Hemabate, so asthma, severe hypertension, those kinds of things. You can still give it, but it's, we're not recommending that as like a second line like we were previously. So that was a big change in this toolkit. TXA, so the tranexamic acid, this has been shown to be very effective if it's given within 3 hours of the hemorrhage. It's not great prophylactically. So there was a lot of question, like, should we be giving TXA to all our cesareans, prior to delivery, all that stuff. So that research hasn't panned out, but postpartum administration of TXA has. Is anyone giving TXA routinely for hemorrhages here? Not prophylactically, yeah. Okay. So blood product replacement, right? We don't take this lightly. We're going to give transfusions if there's an evidence of a hemodynamic compromise, so we really see that impact on our vital signs. There's a high rate or magnitude of blood loss, like this patient's lost, 1,800. You know that they might need some blood replacement, so you want to start thinking about that. And if blood comes up and the patient stabilizes, then you don't necessarily have to give it, but then you have it. What is the etiology of bleeding? Is it atony and you know it's atony, or do you not know what it is? Because if you don't know what it is, you should probably start thinking about, do I need to transfuse or prepare for transfusion, because I don't even know where the bleeding's coming from. What is your response? Do you have adequate resources, again, with your medical and surgical teams? What is the type and degree of cardiovascular support that the patient requires? And do you do lab or point of care data? So point of care testing. So some of our hospitals have those rapid H&H things, so they utilize that pretty readily. The key is that we're not just waiting for a low H&H in order to transfuse, right? That's not the point. The point is to look at the whole clinical picture, and if the patient requires transfusion based on clinical presentation, then we should give it and not wait for whatever the H&H says. So emergency release and massive transfusion protocols. So this is kind of sticky for us even at Stanford. Stanford's like limitless in their resources, right? So all of the doctors that work there think that every hospital's resources are limitless, but they're not, right? Like some of us worked in very small hospitals growing up. So you can't get a massive transfusion protocol necessarily started as quickly as another facility, and you will run out of blood very quickly, right? So these are things to think about. But there's ways to get blood quickly that are not necessarily an MTP. So this emergency release, I don't know if this is utilized by anybody here, but you're able to get 2 units without actually calling a massive transfusion protocol. And this is kind of like when you're iffy situations. If you know the patient is bleeding and continuing to bleed, go ahead and activate your MTP. But if you're like, something's not right here, I don't know what's going on, or it's heavier than I'd like, you can at least get those 2 units in the room, usually in less than 20 minutes. So some hospitals only have an MTP, and that's what they want you to activate, and that's perfectly appropriate. But if you're having trouble accessing blood, you might want to think about this other pathway if you don't already have it. And there is a more detailed explanation of that in the toolkit. We never want to wait for cross-match blood in order to give units. So if the patient needs blood, you're going to give it and figure it out later. So this is Jennifer's thing, DIC. So a lot of times patients are diagnosed with DIC, which is actually a problem with coagulopathy, but what it really is dilutional. So we've given these patients like tons of fluid to treat their hemorrhage, and so it's not really DIC, but it looks like DIC in labs. So it's just something to consider that DIC is actually a really rare occurrence, and it's associated with specific things typically. So amniotic fluid embolism, severe placental abruption, sepsis, if our patients that are unhoused, coming in pregnant, the baby has died, and days, then that's a DIC case, or can be a DIC case. So try to think about like those coexisting things, and is this really DIC, or is it just a dilutional? Our uterine balloons, I love these, recommended for the treatment of atony in situations where uterotonics are contraindicated, ineffective, or unavailable. So it's usually ineffective. That's why we move to the balloon, right? We've given our methogen and our PIT, and it's not working for our atony, and so we go ahead and use the balloons. When we're inserting the balloons, we want to think about next steps. So one of the hospitals that I worked at, we placed balloons in the OR, because we didn't have enough room in the room, we didn't have enough light in the room, we didn't have what we needed, and actually to have a really good visualization, so that if this balloon didn't work, that we weren't going to be able to really move to the next step. So when you're inserting the balloon, getting ready for that, think about what you're going to do if it doesn't work. Do you need to notify the OR to open up? Is that appropriate at your facility? Like, what would the next step be? So not just kind of ending there so that you save yourself minutes. So just think about what the progression should look like when you're utilizing balloons. Do you need to call in additional personnel, activate your OB-RRT? Do you need to activate your massive transfusion protocol? And then I talked about our OR readiness. Success rates for the balloons are actually really good. 68 to 88% of the time, they work really well. Oh God, 5 minutes. So the balloons are pretty effective. I'm sure somebody will ask me about the vacuum, so you'll have to do that later. And you might want to consider placing this with ultrasound guidance to make sure it's in the right spot. Next slide. Oh, compression sutures. So compression sutures are not utilized very often, and there's some thoughts that it's because people kind of forget that they exist, or like they don't have that like trigger. So some ORs will hang up pictures of some of these sutures. The bead lynch has been shown to be pretty commonly used and pretty effective. So I've worked in ORs where they just have a picture of what that suture looks like on the uterus on the wall, just as kind of like a mental trigger. Uterine artery embolization, basically what we're saying in the toolkit is that it should only be utilized in centers that are good at it. So if you are not a center that normally does that, kind of fumbling with a UAE in your facility is probably going to waste time when you could be doing other things like a DNC or hysterectomy that will actually save your patient's life. So if you do go for uterine artery embolization, the recommendation is that there is a physician that is readily available to perform a surgery if necessary. So what is your process for your UAE, and what does that look like? And if you don't have a process, you shouldn't be doing it. We talked about talking to the patients. ED, so patients come into the ED, and we want to make sure that they have the same training. One of the questions that you would want to embed in your triage nurse's toolbox is, have you been pregnant in the last 6 weeks? And some people have extended this for a year because that covers cardiomyopathies. But when we're talking about usually hemorrhage and preeclampsia, that 6 weeks is kind of like the standard. So we want to make sure that our patients, our EDs ask that, and that they activate any OB backup that's necessary. So debriefs and case reviews. Oh, good, I'm going to make it. Debriefs. You want to make sure that the key of debriefs are in real time, right? If we do a debrief tomorrow, it's terrible. It's not good. I'm not going to tell you don't do it, but you're not going to get the information that you want. I know tension is high and everyone's like, adrenaline is going, but debriefing right after the case is when you're going to get the best information. What went well, because we want to make sure, like, okay, that new hemorrhage cart that we got, or the way we put it, or whatever, is making a huge difference. What didn't go well? You know, this physician didn't know that we only have 10 units of ONEC here, whatever it is, so that you can really address those problems and learn from them. And then the case reviews are deeper dives. Then you look at the whole chart from top to bottom, and you can see where any opportunities are. So these are different pieces of communication, where debriefing is more about like resource allocation and what could be done better as a process. And then your chart review is more about like the case, you know, different meds being given or whatever. Outcome measures, so this is how when we look at hemorrhages and if we're doing a good job or a bad job, or we could be doing a better job, we look at severe maternal morbidity, and we look at it with and without transfusions. So if the case is associated with a hemorrhage, you're gonna have more ICD-10 codes than just transfusion. So we kind of pull those cases out, because the ones that just have transfusion are those anemia cases. Again, there's an area for opportunity, but it's not something we can do in our four walls. So kind of the way we evaluate that is a little bit different. And I already talked about some hospitals just evaluate their MTP cases. The process measures are kind of, so those are the numbers. The process measures are the things that you're looking to lay as the foundation for how you treat hemorrhages in your facility. So these are the things like hardwiring your risk assessment. Not, oh, we do it here. Like, how do you do it? Is it in the EHR? Do you use a form? Is it systematic? Does it have all of the assessment pieces on it? Hardwiring quantified blood loss. That's a ground thing that we want to lay down. Getting your debriefs down so that everybody feels the safety of being able to say in real time what went well and what didn't go well, so that you can all learn from the experience and improve. And making sure that you hardwire your staff education. So is there some background information that you need to present, whether it's any of those flow charts or the stage-based care, or is it drills and sims? Is it both of those things? Do we need to highlight things on badge cards or things like that? So we want to make sure that that staff education doesn't just happen for nursing, that providers are also involved in that, including anesthesia. I did it. I don't know if we have time for questions, do we?
Yeah. We do.
Oh, okay. Whew. All right. Don't ask hard ones.
Oh, I am coming.
Hi, thank you. I have a question. I didn't see it come up, and I don't know if you have an answer to this, but one thing I see in practice that's a big variation is the administration of Pitocin, whether it's with the posterior shoulder or with the delivery of the placenta. Does the CMQCC have a recommendation?
No. We don't have a recommendation, and when we looked at the research, it didn't seem to be startling one or the other. So if we don't see something really obvious, we don't usually make a recommendation, and we didn't even actually make a note of that. So
Okay, yeah, I wondered.
Yeah.
Thank you.
Hi. I like smiles.
First of all, adorable outfit.
Oh, thank you.
Second,
I was raised in Jersey. You know, we could do a thing.
that's
Yeah.
what it is. My family's from Jersey. I felt the kinship
felt it,
there
okay.
for you. Do you recommend the use of Cytotec prophylactically?
No.
No.
I mean, not me personally. CMQCC does not.
Okay.
Yeah.
Okay, thank you.
You're welcome. Even, there's not even a whole lot of research. Did I do that? Oh. Back in the day, we used to discharge patients with PO methogen. Did anybody do that or still do that? Yeah, and there's no research to support that whatsoever. So I was like, that's interesting. But we did it for a million years. Anything else?
This was so good. Thank you.
Oh, thanks.
I didn't see mention of emptying the bladder or addressing the bladder as a key factor in atony. It's something that gets overlooked oftentimes,
Yep.
particularly for postpartum kind of hemorrhage when a patient's had anesthesia, but certainly unanesthetized patients as well. Is that in the
It's in the
algorithm?
toolkit. I just didn't say it. It must have
Thank
been on
you.
one of the pages I didn't get to. But you are absolutely right. Yeah, and it seems it's one of those obvious things that gets missed. Absolutely. Anything else? Well, call me.
I think there's,
I was just wondering about when it's not uterine atony, but it is a laceration. We've been seeing some benefit with using TXA as a second line. I mean, because we'll start always with
Yeah.
Pitocin, but then when we identify it, is there any research on that, or is it just
So
something
that
I
was the
noticed?
thing. When TXA first came out, we made this like supplemental addendum because we were on the last version of our toolkit, and we're like, this is good. We don't know when to use it, right? We like in the stage-based care, we didn't know where to put it. A lot of hospitals are using it in that second stage, which again would be that continued bleeding that you don't know where it's from necessarily, or maybe you do know where it's from. But a lot of hospitals are giving it in that stage 2. There isn't like a timing definition other than within 3 hours of the diagnosis of the hemorrhage, which sounds crazy, right? Like 3 hours, that's a long time. But there isn't really a hard wire to that yet. We did much better in the toolkit with narrowing that down to saying, yes, it's beneficial. Prophylactically, it's not. But as a treatment, it is within 3 hours. But what I've been seeing is in that second stage exactly what you're talking about. Yeah.
One last question. Thank you. Thanks for
Did
really
you miss
highlighting.
Elliot? Did you miss Elliot?
I did miss Elliot, but you did an amazing job, and thank you, and Dave LeGroux, obviously. So, Dave and I had always talked about denial and delay,
Yeah.
and we added that third D, which is dismissiveness. And I
Yes.
think what you really highlighted today was it takes the team to really impact patient care. Because too many times we've measured blood loss, but it's that denial, delay, and that she's really not that hypotensive. She's really not that tachycardic. Oh, that's her anxiousness level. So thank you for really bringing it all together as that readiness, recognition, response reporting. And again, I think the added R of that racial and ethnic disparities and respectful care. So thank you.
Oh, thanks. And I would say I'm just a vehicle. I love my work and I love what I do, but everything that I learn is from other people's work, right? So I'm looking at, we are as a team at the task force looking at journals and articles and research that's been done by other people, and then I learn from my hospitals. I learn from all the providers and nurses that work at hospitals and what's successful, what's not successful, all their little tips and tricks, and then I share them with the rest of the state. So California does I think we're at 430,000 births a year. So it's a lot of patients to learn from, but I'm the vehicle in which I share all of their learnings with you. But I'm not that smart. I didn't come up with it all by myself. But I do want to thank you all for the work that you do every day. It's a tough job. It's a tough job. We don't get enough credit for it. Everybody thinks that everything's happy endings on OB. So it's a tough job, but I appreciate all the work that you do and how much you let me learn from all of you and your cool refrigerators that are on your hemorrhage carts. So feel free to email me if you have any other questions, even if it's not about hemorrhage. I answer questions from all over, really the world, but all over the country. And so if there's something that you're struggling with in your hospital and you just want to run it by me, I'm happy to do that. And it's really my favorite part of my job is really interacting with the real people that are doing the work. Thank you.
thank you.